Welcome to Part 2 of the PRA-BC Centralized Orientation online module on Indigenous Health in BC. This online module is intended to be used alongside Part 1 of the online module, as well as the live presentation during the PRA-BC orientation. Our module today will focus on healthcare disparity, which are unequal treatment and outcome arising from within healthcare. This presentation was produced on the traditional and unceded territories of the Squamish, Tsleil-Waututh, and Musqueam nations. I do not have any conflict of interest to disclose. I do not possess lived experience from an Indigenous perspective as I am an Asian settler. This presentation is made from the perspective of a person without lived experience for other providers without lived experience. The focus is on the deficits of the current healthcare system to encourage appropriate response from healthcare providers. It does not claim to represent Indigenous perspectives and values on health and health care. As part of reconciliation, the onus of learning how to mitigate the harms of the healthcare system and work towards health equity rests with settlers. The onus is not on Indigenous peoples to provide this education. This presentation does not seek to replace further training in cultural safety. Rather, it seeks to provide some background and encourage further learning directly from Indigenous voices. While immensely valuable, we do not have an Indigenous co-presenter today. The primary rationale is that many healthcare providers have yet to critically reflect upon and draw lessons from the tremendous input Indigenous voices have already contributed. We seek to draw from some of these lessons today. Personal preparation, including education around context as well as active reflection, is needed in order to optimize learning yield and decrease the risk of causing harm when learning directly from persons with lived experience. The aim of this presentation is to form part of this personal preparation and encourage each participant to learn directly from Indigenous voices when they feel ready. Speaking about Indigenous health from the lens of a non-Indigenous healthcare provider is not an attempt to add validity to Indigenous voices. These voices are intrinsically valid and do not require further validation by persons without lived experience. Our goal for discussing this topic today is an act of knowledge translation in improving the accessibility of this topic to a medical audience. This presentation contained material that benefited from the expert input of Dr. Terry Aldred. In Part 1 of the online module, we reviewed some of the population-wide health status of Indigenous peoples in Canada. We also examined the determinants of health which play a part in contributing to the population-wide health status. In this portion of the online module making up Part 2, we will explore healthcare disparity affecting Indigenous peoples in Canada. In Part 3, which will be a live session, we will focus on the aspect pertaining to healthcare delivery. We will examine how implicit bias and trauma affects the healthcare of Indigenous peoples. We will then explore strategies that each provider can take for improving healthcare delivery. As you have seen through Part 1 of the presentation, there are significant disparities across health status indicators between Indigenous and non-Indigenous peoples in Canada, illustrating the fact that Indigenous peoples in Canada do not reap the same benefits through the Canadian healthcare system, which was meant to serve all Canadians. The roots of the population-level health disparities can be traced to adversities across almost all levels of the determinants of health. These disparities range from the glaring and obvious proximal determinants to the insidious and systemic distal determinants. In this module, we will examine the care Indigenous peoples receive upon accessing healthcare. In an equitable healthcare system, the course of the disease and illness is mitigated. This may result in improved function, quality of life, and outcome. Evidence suggests that Indigenous peoples do not receive the same care as non-Indigenous patients in the healthcare system in a phenomenon known as healthcare disparity. This contributes to the overall health disparity observed at the population level. We will review the three ways that healthcare disparities are manifested: poor patient experience, disparities in investigation and management, and adverse outcome. Increasingly, providers are showing concern regarding the performance of the healthcare system for Indigenous patients. However, some clinicians perceive little inequity in the care of Indigenous patients. The evidence around healthcare disparity refutes these perceptions. We will start by examining how patients experience healthcare. One study of First Nation patients with diabetes in Ontario showed that 18% have not received needed healthcare in the past year, while 24% rated their care as being worse than other Canadians. 15% report unfair or inappropriate treatment from a healthcare provider in the past year. This reflects poor therapeutic alliance and a trusting relationship that could be required for high-quality healthcare. In the year 2020, the BC government commissioned the In Plain Sight report, which examined the experience of Indigenous peoples accessing healthcare in BC. It surveyed 2,780 Indigenous patients and 5,440 healthcare workers. It found that Indigenous patients were 3 times more likely to feel not at all safe in healthcare settings. The feeling of lack of safety in healthcare spans a number of different disciplines and services. Women were significantly less likely to feel completely safe in these settings. The report found evidence of widespread Indigenous-specific stereotyping within the BC healthcare system. Here are 2 examples of healthcare providers sharing their perceptions of Indigenous patients. The report also documented numerous concerns around care quality and experience. The report found that Indigenous patients were many times more likely to have adverse experiences of care, such as being treated as dishonest, insulted, assumed to be using substances, subjected to whispers and pointing, or treated as if they were a bad parent. Indigenous patients were much less likely to receive positive experiences such as respect, being included in care decisions, or having cultural traditions appreciated by staff. This is consistent with the findings of previous qualitative research, which has documented numerous reports of adverse experience. Here are some quotes from participants of these studies sharing their experiences in healthcare. Some of these examples of poor care experiences were also captured quantitatively. First Nations patients who were admitted to hospital were found to spend more time in the emergency department before being transferred to more comfortable care spaces on inpatient units. There are higher rates of patients returning to the emergency department after an initial visit. Indigenous peoples were significantly more likely to leave the emergency department without being seen by a physician. This may reflect poor experiences or disproportionate wait time, resulting in patients choosing to end the encounter early. Indigenous patients are very aware of the numerous ways that the health system contributes to the marginalization, traumatization, and oppression. This can create a disincentive to seek care even in those who have not personally experienced it. This results in delayed care or even care avoidance. Not surprisingly, research shows that discrimination by healthcare providers is positively associated with unmet health needs. Patients who feel that their health services are not culturally appropriate were found to be more likely to have diabetes. In summary, barriers to healthcare system access translates to tangible adverse health outcomes. In addition to poor experiences and interactions, there are also measurable differences in the investigation and management that Indigenous peoples receive. One study in Ontario looked at healthcare system use by First Nations people with diabetes. People with diabetes require excellent primary care and would ideally have a 100% attachment rate to family physicians. For non-Indigenous peoples, the attachment rate comes close at 97.7%, compared to 85.3% for First Nations patients. Even for those who have a family physician, continuity of care tends to be lower. The proportion that are under the care of specialists is also lower. There's a twofold higher risk of admission for ambulatory care sensitive conditions and emergency department visits for hypo or hyperglycemia. Overall, this reflects a poorer level of primary care for First Nations patients compared to the general population. In BC, the attachment rate to family physicians for First Nations patients is significantly lower than non-First Nations patients. Not being attached to a family physician is associated with lower use of outpatient services in the community and increased risk of needing care in the emergency department and hospital. Indigenous patients also have a substantially lower rate of receiving care from specialists compared to non-Indigenous patients. This phenomenon is not driven by rurality or socioeconomic status. When First Nations patients do present to the emergency department, there is a lower likelihood of being triaged as urgent. While this could be in part due to poor access to primary care in the community, those who are triaged as having lower acuity have a higher admission rate to hospital than expected. This raises the potential that there may be under-triaging. In areas with higher percentage of First Nations populations, patients with acute myocardial infarction are less likely to receive revascularization by percutaneous intervention. Correcting for rurality only slightly reduces this disparity. Indigenous patients with arthritis are less likely to receive care from a specialist and receive joint replacement. There is a higher likelihood of hospitalization. Compared to Caucasian patients, Indigenous youth are less likely to receive renal transplants. While the rate of referral for consideration of transplant is similar, there are lower rates of completion of the prerequisite steps among Indigenous patients. This raises the concern that Indigenous patients may have inadequate support or face additional barriers in the pre-surgical process that may require optimization. After a major osteoporotic fracture, First Nations patients were less likely to receive a bone mineral density test and become diagnosed with osteoporosis. Not surprisingly, there is a lower likelihood of receiving osteoporosis-related medications. Evidence shows that Indigenous patients do not receive the same care as non-Indigenous patients. The causes of these disparities are likely to be multifactorial. However, it is unlikely that patients choosing not to pursue care accounts for all of these differences. For example, the decision to diagnose someone with osteoporosis is entirely made by the clinician. This decision then has implications on treatment, as it is even less likely for someone to receive treatment for a condition if that condition was never considered as part of the differential diagnosis. Differences in revascularization after acute myocardial infarction is also unlikely to be significantly affected by patient's choice, given the short time between admission to hospital and when revascularization would normally occur. Therefore, provider factors likely play a role in these disparities. Communication and trust between the provider and the patient, as well as barriers in accessing healthcare, likely also play some role, as seen in the case of renal transplant, where the rates of referral is similar, but the rates of completed transplants are lower amongst Indigenous patients. When patients do receive treatments, there are outcome disparities between Indigenous and non-Indigenous patients. A recent systematic review examined post-operative outcomes for Indigenous peoples in Canada. It was found that Indigenous patients have a 30% higher post-operative mortality rate compared to non-Indigenous peoples. There are also higher rates of complications such as surgical site infections and pneumonia. Among Indigenous patients treated with biologic therapy for rheumatoid arthritis, there are substantially higher rates of complications such as infections or all-cause hospitalization. The likelihood of achieving remission is also lower. Some possible contributors to these observations include barriers to accessing rheumatoid arthritis care, leading to a higher severity of disease when patients do get started on biologics. Other factors may include comorbid cigarette use, intergenerational trauma, chronic stress, and geographic location. Examining the interaction between Indigenous patients and the healthcare system reveals that Indigenous patients do not receive the same care as non-Indigenous peoples in Canada. These healthcare disparities may manifest in poor patient experiences, differences in investigations and management, as well as poor health outcome from the treatment received. As healthcare providers, we need to be aware of these healthcare disparities, as they may decrease confidence towards the health system among Indigenous patients. We then have the responsibility to critically examine how our own care, as well as system factors, may interact to produce these disparities in order to mitigate them. We will examine some strategies that we can take in our live session. Thank you for your attention.